So I was charged to talk about GIST, which actually I found kind of a difficult charge, not because I didn't know anything about it, but because I was told that I should cover the basics, but then I was told, but don't be too basic because there's a lot of people like Jerry in the audience who practically have a PhD in GIST, we need to challenge them. So I was struggling with that for a while, but I took inspiration from the recent presidential elections. And so what I decided was that if 50% of you thought that my talk was too basic, but you did learn a few things, and the other 50% thought it was too complex, but you did learn a few things, then that would be the great compromise, and I would have succeeded. So just by way of explaining my slide, so I live in the Northwest. This is Mount St. Helens, which is an active volcano. And so occasionally, if you fly from Portland to Seattle, you can look outside the window of your Alaska airplane and see this type of mountain, which is a little bit different than the mountains we're seeing today. So what I'd like to talk to you about is just obviously background and some of the molecular biology as it relates to how we treat it. Talk about first-line therapy of metastatic disease, which is, of course, Gleevec. Talk about adjuvant therapy, which is the therapy we give after surgery to prevent recurrence. And then, of course, talk about the great unsolved problem that we've all been working so hard in the research and clinical world, which is what do we do when Gleevec doesn't work? Tumors that become resistant, why did they become resistant, and what can we do about it? So, you know, if you went back in time 14 years ago, there would not be a disease called GI stromal tumors. There would be something called leiomyosarcoma or some other name. And the reason for that is that, I don't know if Brian left, so there's no pathologist in the room perhaps. So if you look at, on the bottom, something called a leiomyoma, which is a smooth muscle tumor, and look at the top, which is a, quote, benign GIST, or at least a low-risk GIST, you can see that they look fairly identical. And pathologists looking at them couldn't tell them apart either. And it really was no better looking at the high end, so looking at GISTs that are obviously malignant, or looking at malignant leiomyosarcoma, there is really no morphologic difference. And so there are still patients running around who were diagnosed in the 90s, who originally diagnosed with leiomyosarcoma, and it was only after 1998 that their diagnosis changed. And the reason everything changed in this field in 1998 was this very important paper published by a Japanese group led by Keiichi Hiroto, which I believe he's in the GIST Hall of Fame, deservedly so. And he made the important observation for the first time that the KIT protein was expressed by almost all of these GIST tumors, which no one had ever made that observation. And more importantly, as it turns out for the development of Gleevec, he found that not only was the KIT protein present, but it was mutated and it was active. So it was doing something that it wasn't designed to do, and that gave us a clue as to what was going on. And so pathologists are very good at looking at tissues and being able to tell if a protein is expressed. So you can take some tissue which has been removed from somebody's tumor, it's been fixed in formalin so it doesn't, degrade or rot away, and then you stick it in wax to make it hard, and then you can shave incredibly small sections of it and put it on a glass slide, and you can stain it and look at it. So here is a KIT stain. So we put an antibody on this section of tumor or of tissue, and then we react against the KIT protein with a chemical which deposits brown pigment. And so you can see that this part of the tissue, which is normal, does not express the KIT protein, and all of the tumor cells are strongly brown or express the KIT protein. And this is one of the basic techniques that pathologists do. And so if you've ever read your pathology report, they talk about CD117 or KIT and how your tumor is positive. And so in 1998, this provided a more specific marker for diagnosis. It also allowed us to realize that these things arise not just in the stomach, which is what historically people had recognized, but in other, the small intestine, large intestine, other abdominal sites as well. It also provided us a clue to the cell of origin. So GIST, as you know, arise in the wall of the stomach or in the wall of the small bowel. And normally in those regions, the only normal KIT positive cells are the interstitial cells of Cajal, which Brian was talking about, which are the pacemaker cells that kind of move food through from one end to the other. And so it led to the hypothesis that GIST arise from the interstitial cells of Cajal. This is a stamp of Santiago Ramon Cajal, who won the Nobel Prize in anatomy. He was also quite a gifted artist, but this is one of his sort of original diagrams of the interstitial cells of Cajal network. And so now it's become fairly routine that pathologists can look at something from the stomach and suspect GIST, and now we can do a CD117 stain and confirm the diagnosis. Now there are other things that can arise in the same organs, like here is actually a gastric leiomyosarcoma, and this is the tumor down here, this is the lining of the stomach. And again, Brian's not here to contradict me, but I think he would agree that this is a spindle cell neoplasm arising in the stomach, and your leading consideration would be that this is in fact a GIST. However, if you did the CD117 stain, you can see all the tumor cells are blue. These brown cells are actually normal mast cells, which are a type of blood cell, and it's okay for them to be KIT positive. So we know that the stain is working. The tumor does not express CD117. However, it does express another protein called desmin, and so smart pathologists like Dr. Corliss or Dr. Rubin can take the slide, look at the cells, look at these stains, and rapidly arrive at the correct diagnosis. And I'm glad to say that, since the year 2000, that almost in all cases GIST is accurately diagnosed. You should always, if you have a somewhat uncommon tumor, you should always have your pathologist reviewed by someone who really knows what they're looking at. But in general, even in a referral basis that I have, we rarely see patients who have been misdiagnosed, which is a great thing. So we now, with the ability to diagnose these things accurately, we now know that about 70% of GIST arise in the stomach, 20 to 30% in the small intestine, about 5% in the colon. But we've also recognized that these tumors can arise in other places that we had never suspected, like the esophagus, the gallbladder, and other various sites. So having been able to diagnose them, we can now actually make a statement. Well, what is GIST? So GIST is a mesenchymal gut neoplasm, which is a medical term. It means it's a sarcoma of the abdomen or the gut. And we now realize that this is its own disease. It's different from leiomyosarcoma. It's different from other things it looks like. It likely shares some common ancestor with the interstitial cells of Cajal. These cells are probably the stem cells for the tumor, and I'll come back to that and I'll sort of amplify a little bit what Dr. Rubin was telling you. We know that these most commonly present in the stomach. And back in the day when we were first trying to do our first phase 2 trial, we actually thought there were only 300 new cases of GIST in the United States. That's the best data we could come up with in 1999 when we approached Novartis wanting to do a trial. We now realize that there's about 5,000 to 6,000 new cases in the United States. And so that's the incidence. Because people are living longer with GIST, there's actually quite a few people with GIST in the United States. So I would guess that there's probably 50,000 patients with GIST or more in the United States at the current time. Now, as you may not know, or you may know, depending on how long you've had a GIST diagnosis, prior to the year 2000, we didn't have any way to treat this other than surgery. So there was no pill, there was no chemotherapy, there was no radiation, there was no hormone, there was nothing that we could do besides surgery. So surgery either helped you or it didn't. How does GIST present? Well, oftentimes they don't cause any symptoms at all, especially when they're small. So a lot of people have endoscopies because they're expected to, they have some kind of vague heartburn or whatnot, and they may have an ulcer, they may have a bacterial infection of the stomach, but our endoscopists have gotten very clever and have learned about GIST, and they often find very small GISTs in the stomach, which are only 1 or 2 centimeters. However, as these get bigger, as you know probably, they can cause symptoms, and the symptoms relate to where the tumor is. So this could be some form of abdominal pain. These tumors often bleed when they're bigger, so that can show up as sort of a more dramatic bleeding event, or it may show up as chronic anemia, or it just can be something's not right, and eventually your doctor does enough tests and figures out what's wrong. And occasionally these can present as a surgical emergency because they can perforate or have very dramatic bleeding that leads people to be hospitalized and go straight to surgery. Now, one of the things we've learned about tumors over time is that they're not all the same. And so the risk of recurrence varies by tumor. So one of the variations is related to size. And as you could kind of imagine, since we're talking about cancer, that a smaller tumor is less risky to recur than a larger tumor. And so this is what's called recurrence-free survival. So we start with everybody had surgery and nobody had recurrence, and people are followed over time. So this is months. And so not surprisingly, bigger tumors are more risky for recurrence, although even large tumors don't necessarily recur. The other thing the pathologists realized by looking at it, and this is a gist, is that there's these things called mitotic figures that are interesting. So mitotic figures relate to when DNA is condensed. So normally DNA is kind of all spread out, but when a cell has to divide, the DNA has to clump together, and then you can recognize it. So in the context of us being here, I think of normally, think of the clothes, like the clothes at my house. So I have clothes in my closet, I have clothes in a dresser, there's some in my gym bag, there's some down in the laundry room, clothes are everywhere. But when I come on this trip, I take clothes and I compact them and I put them into a suitcase, and then they're easier to find. So the pathologist can recognize that these are dividing cells, and they can count them, and that's what's something called the mitotic index. Now, it relates to how much magnification is necessary, because microscopes could make things not so big, or they could make them really big. And so they talk about high-powered fields. This is kind of an older slide, so it talks about 30 high-powered fields. Now we've kind of standardized it to 50 high-powered fields. But if the tumor does not have a lot of dividing cells or mitotic figures, then the risk of recurrence is favorable, that 90% or 95% of these patients didn't have recurrence. Down here you could see if there's a lot of mitotic activity, these are risky tumors. And understanding this has helped a lot in the adjuvant setting in terms of risk stratification. So we know that the tumor location, the tumor size, and the mitotic index go into determining whether you have a 2% of recurrence or whether you have a 95% of recurrence. And how you are treated after surgery ought to be tailored individually to your risk. So what is KIT and how does that relate? So KIT is a type of protein. So this is the cell, the outside of the cell, this is outside of the cell, this is the membrane, this is the inside of the cell. So KIT goes through the membrane, partly outside, partly inside. We'll come back to what these different regions do in a second. But this is just showing where mutations occur. So KIT exon 11 is the most common, 70%. That turns out to be a good thing because that's the most drug responsive form of GIST. We have KIT exon 9, which is not as drug responsive. We'll come back to that. And then we have more rare types of KIT mutations. And then we have mutations we discovered about 10 years ago in platelet-derived growth factor receptor alpha. It's a lot less common, so it's about 7.5%. And overall, 86% of GIST have a mutation of one or the other. And thus far, in I guess this is now 3,000 or 4,000 GIST that we've analyzed, we've never found a GIST that had a mutation of both. They only need one of them to be active. So what does KIT do? So this is what the normal KIT protein is designed to do. So here's the outside of the cell, here's the inside of the cell. And normally the KIT protein just sits by itself, it's all alone, it's not doing anything. But if a hormone flies around known as KIT ligand, it will cause these cells to be bound together. So this is sort of a glue that brings them together. And when you bring them together, you twist the protein so that the inside, which is an enzyme, or that's the kinase that Brian was talking about, this becomes activated. And this can take something known as ATP, which is a storage form of energy, and transfer that energy to other proteins to activate it. So this results in signaling. But this is a very binary system. So if this is present, the whole thing is turned on. If it's not present, it's not turned on. So it's just like diabetes and insulin. If insulin's around, you can regulate your glucose. If insulin's not around, your glucose will tend to be higher. But what happens in GIST is that these mutations of the protein result in the KIT receptor being activated. Notice we don't have our hormone or our normal growth signal up there. So the whole thing's turned on, and it's just turned on all the time. So it's just an out-of-control engine for the cell. Now, we were very excited when we were able to carve out GIST from leiomyosarcoma and other sarcomas, and we had our own disease. But you have to be careful for what you wish for, because now we realize that GIST is not one thing. GIST is actually 14 or 20 diseases that have similarities, but they also have differences. And so it's heterogeneous. It's a lot of things linked by what's wrong in the cell. What they share is that they all pretty much look the same, and they all started with the same cell, which is the interstitial cells of Cajal. Most GIST are driven by either KIT or PDGFRA or something else, which is a mutant kinase, which is good because we can drug it. But depending on what's wrong, impacts quite a bit how people will respond to therapy. So whether Gleevec will work or not work is determined in large extent by what's wrong in the tumor. So not to go through this whole thing, but this is just one way of now classifying GIST. And now you can see that we have lots of lines here, each one representing a different flavor or type of GIST. We can lump them together by KIT mutation, PDGFRA mutation. Down here is the so-called wild-type GIST. Wild-type is a genetic term meaning that we don't find a mutation, but it's not a very good term anymore because these things actually have mutations of things other than KIT or PDGFRA, BRAF, succinate dehydrogenase genes, RAS genes, neurofibromatosis genes, and then there's still pediatric and carny triad GIST, which are rare, but we don't actually know what's wrong in them, and even they are probably multiple diseases. So the table of GIST will only get more complicated as we learn more. Now, oncologists like to come up with acronyms for giving chemotherapy that are sort of catchy and help you remember. But this would be the acronym we'd have to apply for chemotherapy for GIST, failure, because none of these things work. And back in the 90s, before we could diagnose GIST, all patients with GIST were treated with chemotherapy. But what oncologists learned, even before we knew there was GIST, we learned that sarcomas of the stomach seem to never respond to chemotherapy, whereas sarcomas of other sites in the abdomen sometimes did. So we learned the hard way, especially once we could diagnose GIST, that chemotherapy doesn't work. The response rate at best is 5%. For most agents, it's probably 0.01%. And even if it arguably shrinks a tumor, it doesn't have much of an effect because within 3 to 4 months, you've already failed, and the chemotherapy is very aggressive and has tons of side effects, doesn't make you live any longer. Radiation is something we don't use too much for GIST because mostly radiating the abdomen has a lot of side effects. There are certain locations where radiation might be helpful for GIST, like rectal tumors. So historically, surgery was the principal treatment, and that remains true. So if you have an isolated GIST, you should have surgery, and then we'll figure out what to do afterwards. Now, how we got to where we are today was realizing that this was the mutant kit, this was all the signaling, and that this energy source known as ATP has to bind into this protein. And what we figured out in the lab, and Jonathan Fletcher and other groups figured out around the same time, was that Gleevec mimics ATP and can stick in there, and it actually binds more tightly than ATP, which is the energy source. So when you stick Gleevec into KIT, you turn it off, and that there's no longer any signaling. This led eventually, with a little bit of struggle, to doing a trial, which is the original phase 2 trial, was supposed to be a small trial of 20 patients. It proved wildly successful, so it quickly went to 147 patients. And remarkably, so we started with chemotherapy work 0% of the time, And in this study, 83% of the patients had some benefit. Either their tumors shrank, and we'll kind of come back to this a little bit, or the tumors stopped growing. The median time to progression in this study was 84 weeks. The median overall survival is 57 months, or almost 5 years. And for the first time, so Gleevec was originally diagnosed or developed for leukemia. There was a lot of concern giving it to patients with GIST because they might not have a stomach, they might be missing part of their small intestine or their liver. So would this drug actually be safe in patients who had all this extensive surgery? And it turned out the answer was yes. Remarkably, as you may know, some patients are still on this trial. So this is the 9-year follow-up. 14% of patients are still progression-free. I'm seeing some people in my clinic who started in 2000 who have never progressed, who are on the original trial, showing that in some patients this works beyond belief, and that a third of the patients were still alive at 9 years from the original trial. This is just to show you where we came from. So this is chemotherapy from a couple of trials. We know that this doesn't work, so this is essentially looking at what happens to patients with GIST if they're not getting anything that works. Comparing it to Gleevec, we have a big shift. This is sort of an early curve, so we now have almost 10 years of follow-up. And as you know, in some patients, this is quite dramatic. This is historical slides. So in 2001, the original data from the phase 2 trial was presented at ASCO, and this is one of the slides that was showing one of our patients who had a very large, bulky tumor. So this is the pelvic bone. It's like a CT, so the patient's been cut in half. This is a very large tumor. This is the rectum, which is really the only normal part of this whole slide or slice. And 6 months later, then the small bowel, which was being pushed up out of the abdomen by the tumor, has now dropped down. But the tumor has not disappeared. There's still something that you can see. And this highlights that in some people there's quite dramatic shrinkage, but it's rare for patients with GIST to ever have the tumor completely disappear on their CT scan. But it turned out that it doesn't actually matter how much your tumor shrinks as long as it doesn't grow. Now historically, when we were dealing with chemotherapy, we always thought that if the tumor doesn't shrink, it can't possibly help anyone. But what we learned with Gleevec is that as long as the tumor is not growing, you will live longer than if the tumor is growing. So this is taking people who had their tumors shrink by 50 to 99%, comparing it to people whose tumors shrank somewhere between 0 and 50%, and the survival is the same. The only thing that differs is if you're resistant to Gleevec, and these are people whose tumors started growing from the beginning, then you will have a lot less favorable survival. So we had to change the oncology paradigm because we don't really pay attention to response so much as we look at how well people survive. For how long will the treatment work, and how long will people live overall? From doing lots of trials, we've also learned, going back to our theme of that not all GISTs are the same, we learned that not all GISTs are the same. So if you look at patients with metastatic GIST and you try to figure out which dose of Gleevec you should give them, what we learned is that patients who have KIT exon 9 mutations treated with standard dose Gleevec at 400, a lot of them fail in the first several months. However, if you gave them sort of double dose, or what we call high dose Gleevec, then their progression is a lot more favorable, and they actually shift out by more than a year. Now, if you take every other form of GIST with a KIT exon 11 mutation or wild type or everything else lumped together, it doesn't really matter whether you give them 400 or 800 because their survival is the same. That's progression-free survival. We saw the same thing from overall survival. So based on those results, this is my recommendation, although it remains somewhat controversial, but patients with KIT exon 9, I believe, should be dosed to 800 milligrams. I start at 400 and escalate them up over several months. Everybody else with a KIT mutation should start at 400 milligrams. And this goes back to Norman's point last night, that without mutation testing, you can't know what you're doing. You can't make the right decision. And there are other patients, such as the D842V mutation, that I wouldn't even give Gleevec to because I know that it's not going to work, and I would be moving them onto the crenolinib trial because at least we have substantial optimism that that drug works in a test tube, and now we have some evidence it works in patients as well. Now, one of the other things about Gleevec that sort of changed the paradigm of oncology is that with chemotherapy, it's not possible to treat people continuously because it's too toxic. In fact, sometimes people can only be treated with chemotherapy for a few months. Gleevec obviously has a much better tolerance profile than chemotherapy. Not that it has no side effects, not that it doesn't affect your life, but it's something that you could take every day if your doctor can help you with side effects and manage those kinds of things. But the question was, how long is long enough? And so this is a study from the French sarcoma group who took patients who had metastatic GIST and treated them with Gleevec. And those patients who made it to 3 years, which of course would not be everybody, but those people who made it to 3 years without progression were then randomized to say, let's continue your Gleevec. That's what we would normally do. But maybe, you've done great for 3 years. Maybe you don't need to take Gleevec any longer. Let's stop the therapy and watch you carefully to see what would happen. And unfortunately, what we learned is that if you stop Gleevec even after 3 years, and now they've done the same thing after 5 years, is that the tumors wake up. They must have been hibernating, and they start growing, and this is looking at failure. So every time the curve goes down, that means somebody has relapsed. And you can see that at 1 year, almost 70% of patients had progression, and at 2 years, 84% had progression. Now, fortunately, you could restart the drug and recapture your control. But if you look at the people who continued Gleevec, you can see that they did quite well. This also illustrates something that I told you, that the median time to failure on Gleevec is around 2 years. But if you make it to 3 years, then your chance of making it 3 more years is quite excellent. So there are definitely a subset of patients who do very well in the long run. But what these curves are telling us is 2 different things. So this is resistance, which we'll come back to. That is, keep taking the drug, but the tumor figures out a way to resist it. This is persistence. So the disease was there, and we thought it was not there, but when we stopped the therapy, it came back. And what we've begun to learn from work from Brian and Thomas Ordog that Brian Rubin just showed you is that if you think about GIST, then you can think about there's actually 3 different populations. So most of a large tumor is made up of these cells. These cells are sensitive to Gleevec, so when we treat the tumor, we can impact these cells. But the stem cells, as it turns out, are resistant to Gleevec. They like KIT, but they're not addicted to KIT, so they could take it either way. And they have other ways to survive. And so unfortunately, when we treat patients, what we believe happens is that we get rid of all of these things, or at least put them into hibernation. But there's always some cells around that we've never gotten rid of. And that's really the next big challenge for the field is how can we get rid of those cells so that one day we can stop therapy of all types and that we would have a cure. So persistent versus resistant. Persistence is the cells that remain viable during drug treatment and start growing again when you interrupt the therapy. And these are eventually the cells that can give rise to future drug resistance. This applies not only to the metastatic setting, but if you think about patients who have surgery, who take Gleevec for 3 years or whatnot, but then 2 years later their tumor comes back, these cells must have been around as well. There were persistent cells that were not eliminated by surgery or Gleevec, and after time they woke up and started growing. This is different from disease resistance, which is the tumor grows despite what we're doing. Adjuvant therapy. So adjuvant therapy is the medical term for when we give you something after surgery so that you will do better than just surgery alone. And it's quite common in diseases like breast cancer, colon cancer, lung cancer, and now it's common in GIST. And it's based on a couple of trials, which I'll show you. The oldest one is Z9001, which is a randomization of people whose tumors were bigger than 3 centimeters and had a resection were randomized to take Gleevec for a year or placebo for a year with the goal of seeing whether we could decrease relapses. And this is the main result. This shaded area of the first 12 months is to remind us that the patients were on Gleevec for 12 months. And you can see that during the 12 months of treatment, hardly anyone taking Gleevec, only 2% of patients had any relapse, whereas around 18% of patients taking placebo had relapse, And over time, the patients taking Gleevec did well for about 2 years, and then there were some progressions, and now the curves are much closer together. And we haven't seen the longer-term view to see, do the curves always remain separated, or do they come back together? So we learned that 1 year of therapy decreases relapse-free survival. It doesn't affect overall survival, at least not yet. And another important point was we weren't sure to give people Gleevec after major surgery whether that actually would be safe, because maybe they would have more complications, but it turned out to be completely safe. So based on that study, a study was performed in Scandinavia and Germany looking at 1 year of therapy versus 3 years of therapy. Now this was a little bit different trial. So the first trial looked at any GIST more than 3 centimeters. This trial looked at only patients who had pretty high-risk tumors. So more than 10 centimeters, more than 10 mitosis per high-powered field, or a combination of 5 plus 5. So this is not every GIST that has surgery. This is the higher-risk GIST. But just like the first trial, we saw that taking Gleevec was beneficial. But in this case, this is patients taking Gleevec for 3 years versus the yellow curve is people who took Gleevec for the standard 1 year. And you can see that at the end of 3 years, there's quite a big separation in favor of taking it for 3 years, which diminishes a little bit, but still remains quite separate even at 5 years. Now, whether these curves will eventually come together or not still remains an open question. But one of the most important findings of the study, and one that's a little controversial even at this point, is that unexpectedly, we saw that there was a survival advantage. So taking Gleevec for 3 years, 92% of patients were alive at 5 years as opposed to 82% if you only took it for 3 years. The reason I'm saying this is surprising is that we can rescue people who recur following adjuvant Gleevec by giving them Gleevec, and we expect that those patients can live half a decade or more. So it's a little surprising that people could take Gleevec for a year and then have such a bad GIST that they wouldn't have lived to this point in time. And these are very small numbers, so even though this is a big difference, we're talking about 20 people versus 11. And so, there could be other reasons. I mean, 3 people could have been in a bus accident that had nothing to do with this treatment. So we're very excited about this. We think this is very important, but we'd also like it to see it be validated with longer time point follow-up. Now, one question that remains, though, is what is really the optimal endpoint? So the way these studies are designed is that people get a treatment with Gleevec and they get another treatment, which could be, in the first trial was placebo. In the second trial, this was 1 year, this is 3 years. And what we did is say, well, when did the tumor come back? And that's our endpoint of success. But that's not the end of the story, because when it comes back, we will give you Gleevec again, and it will probably work. And at some point in the future, it won't work, which is time to treatment on imatinib failure. And then obviously, if we can't control the disease, eventually that will affect overall survival. So a different way of looking at this question would be not to look at progression-free survival, but to look at this point. So from the day you're diagnosed with GIST to the day that you have metastatic disease and imatinib doesn't work, are you better or worse off to take it early or late? Because that's the ultimate question. If we're only going to control it for 9.5 years, how do I get the 9.5 years? Is it this arm or this arm? And that's what we don't really know. And that's an important question for people in terms of deciding about what they want to do. So the French are actually doing a study, which is 0 versus 2 years, and this is their endpoint, not this, because we know that not taking Gleevec will probably make this be shorter, but is this time longer if you wait to take Gleevec, or is it the same, or is it shorter if you take Gleevec up front? So that'll be a very important study, and hopefully we'll have the results on that in a couple of years, I'm thinking. And so really, the early studies tested early versus late imatinib therapy, but these other endpoints of survival or time to treatment failure might be more informative, especially in terms of making decisions about, do I want to take Gleevec now, or do I want to take Gleevec in the future? what's my best strategy to get me to 10 years, 20 years, or to never have it come back. So talking about more advanced disease, so disease that's recurred, disease that's been treated with Gleevec, and now we have the unfortunate situation that your disease is no longer responding to Gleevec, which is what we call Gleevec-resistant disease. And you can break this down into sort of two different flavors. One is primary or immediate resistance, which means basically we gave you Gleevec and it didn't work. And in the first 6 months, we decided that it wasn't working. That usually relates back to something about the tumor that could have been known by your oncologist at the start, that it was a wild-type tumor, that it was a KIT exon 9 and you were on the wrong dose, or that you had a PDGFRA D842V and it was almost impossible that you were going to respond to Gleevec, and so perhaps you shouldn't have taken it in the first place if you had an alternative treatment. Secondary or delayed resistance is that the Gleevec is working for some period of time, but then later on, the oncologist starts seeing things on the CT scan or the MRI scan that worries him. And this usually relates to the development of secondary kinase mutations, and I'll show you what that means. But basically, KIT's the target, it's a lock and key. The lock is the kinase, the key is the drug, and that darn lock got changed, and our key doesn't work anymore, so we can't open the door that we want to open. Fortunately, we can use other keys, but that's the type of strategies we have to think about. So how does that show up? What does your doctor see? Well, sometimes that means that you may have many tumors, but only one of them is causing a problem, which we call focal progression, and I'll show you an example in a CT scan of what we're talking about. Sometimes it's worse than that. So sometimes many tumors are growing, or sometimes new tumors show up that you didn't have before, or at least your doctor never told you about. So this is a CT scan showing what happens with the development. So this is a CT scan. This is the liver. The black stuff is the air in the lungs. And so these black holes are GIST that have been treated. And this is actually probably a year or two into treatment. So if we went this way, if this is a timeline, sometime over here, these tumors would have been bigger and nastier looking. But when you treat them, they become pretty dormant. But on this scan, I don't know if it projects very well in this room, there's little white dots, which white dot means increased density, increased blood flow. So these are little tumors that are growing inside of the pre-existing cavity. And over time, you can see that they fill up the space. Now, one thing that's important to note, especially if you're an informed patient and you read your radiology reports, is that a lot of times radiologists only measure things. So if you measure this, that and that are the same. If they don't talk about what's going on the inside, you're missing part of the story. Or if your doctor tells you that everything's fine because it's the same size, but you read that there's new nodules appearing, that's something you need to discuss with your doctor, because those are signs of progression that are early warning. So within 6 months or a year, these things will fill up the space, and you can see this tumor now is actually gone from kind of 1 to 3. So over time, these early warning signs will no longer be early warning signs. They'll just be bad disease. There are other scans that are a little bit easier to interpret. So your oncologist, if this is what you look like and this is when you're taking Gleevec, you can see that this is bigger than that. Your oncologist is not going to miss that. Or if you have a new lesion which wasn't there before, your oncologist isn't going to miss that. This they might miss. This is another example. So here is this mass. It's mostly treated. There's a little bit of something going on here that's alive. And on Gleevec, it's more alive, so it's resistant. But if you didn't have this going on, your radiologist and your oncologist might miss that and not tell you that there's a problem. We've learned that even when Gleevec or drugs are not doing something, they're actually doing something. So this is a PET scan, and as you may know, PET scan is looking at radioactive glucose uptake. So we're looking at activity of tumors. So this is a patient who is going actually from Gleevec to one of the first Sutent trials, and you can see that a number of tumors have activity. They're taking up the sugar tracer, which means that they're resistant and they're totally happy despite being on Gleevec. And for safety, they had to stop their drug for 3 weeks to wash it out before they could start Sutent. And what you see is that the tumors were active become more active, and tumors like this that were fairly well controlled become much more active. And so, we believe that patients should always be on some form of kinase suppression, even when the drug's not working, even when you can't come up with another drug, you still are probably better off to have partial control than to have no control. Now, why do the tumors become resistant? So this is our friend the KIT molecule again. We've kind of exploded it up to look only at the inside. And so there are regions of the protein which become mutated when it becomes drug resistant. And these relate to how it's a lock and key, so it's got to fit in there, and it's a pretty tight fit. So if you start changing the fit by mutating these particular parts of the protein, then the drug, this protein becomes resistant. So red means resistant, yellow means it's pretty resistant, but maybe if you took enough Gleevec, it might partially work. And so this is why tumors become resistant to Gleevec, at least KIT mutant ones. They get these secondary mutations. So what do we do about it? First thing to do would be to increase your Gleevec dose. Also kind of figure out what's going on. Am I dealing with one thing or am I dealing with 15 things? Normally you can figure this out just with a CT scan. Sometimes we need PET scans. I'm not a big fan of PET scans. I know a lot of oncologists do them. They're more expensive, they're more radiation, and in some GIST they're frankly misleading because there are types of GIST, like wild type GIST, that the PET scan does not really relate to how the drug is working. So I saw one patient who was on their 6th drug based on their PET scan, and I asked the radiologist, like, okay, ignore the PET part of it, measure all of these tumors. Has any of these tumors actually increased in size? And no. So instead of failing 6 drugs, the person actually was controlled on all 6 of them and needn't have switched from drug to drug to drug. So there are tumors in which it can be completely misleading. Also, there's sort of practical things. Your insurance company tends to get mad at the doctor if you order too many PET scans, and then they'll just say no. And then if you really need one, you won't be able to get one. Once you know what's going on, you could think about surgery. I'll come back to that. You could think about radiofrequency ablation, which is sort of sticking a catheter into a liver tumor and kind of microwaving it from the inside to kill it. Or if none of these work or seem plausible, then we go on to Sutent or sunitinib. Now, this is just one slide about dose escalation. So these are people who originally were treated with 400 and then switched to 800. And then this is looking, how did they do after the switch? So overall, this is not a very good strategy. Most people will fail within 3 months. But there are some people, like 40% of people, will still have disease control at a year. And then there's these people, around 10 or 20%, who almost 5 years later, they have disease control. We don't really understand this completely, but I suspect it's some people have lower drug levels, and some people just need to be on 800. If we had drug levels, we might be able to figure that out ourselves, but you don't want to be the 20% of people that don't need to switch to Sutent, that they could stay on Gleevec. On the other hand, because we expect this not to work, your oncologist shouldn't say double the dose of Gleevec and come back in 9 months or a year, because we expect in 3 months, most people are going to need to do something different. But I think this is always worth trying. In terms of thinking about surgery, the way we think about it is what's going on with your disease. So here are active tumors that are in white, and then we treat them with Gleevec. They become these black holes. They're hibernating. But then you can have progression, which could be all of the tumors are progressing, one of the tumors is progressing, or even only a portion of one of the tumors are progressing. And these are quite a bit different if we think about surgery. So this is a little bit of a complicated slide, but these are patients who are treated either with GIST or Gleevec then Sutent who went to surgery. And what we're looking at is recurrence after surgery based on what was going on before surgery. So if you went into surgery and all of your disease was controlled, then surgery was quite effective for controlling your disease. On the other hand, remember I told you that some people can take Gleevec for 12 years. and you could have done surgery 10 years ago and you would have thought the surgery did something. So people who are doing well on Gleevec can sometimes continue to do well for very long periods of time. So did adding surgery actually help these people or not is controversial. If you go into surgery and you only have a few lesions that are progressing, then it sort of works, but unfortunately most people will have recurrence within the first year of surgery. And if you go into surgery and nothing is being controlled, then nothing is controlled after surgery. And discouragingly, your first scan after you get your stitches out will show that the gist is back no matter the operation. And so I spend a lot of time talking to patients about these issues. Our general thinking is that surgery may add to pills, but you need to have a pill that works. So if we can't identify before surgery a pill that works, we don't have much confidence that after surgery we're going to have a pill that works. And so our preference is to switch to a new pill, get it working, and if it works, then go to surgery and continue to take drug A, B, C, D, whatever drug you're on, take it after surgery, because we don't want this situation where people have very complicated surgeries. Usually these go quite well, but sometimes people can take 4 or 6 months to heal up from a major liver surgery, and we don't want to find out that 3 months before they're even healed up that they have problems with their disease. So it's very tricky, and lots of doctors say, oh, I can cut that out, no problem, but you really need to talk to someone who's a specialist, who's very thoughtful, and who can counsel you correctly about how to manage drugs and surgery and when to combine them and when not to. Now, in terms of Gleevec versus Sutent, these are the targets of the drug. Gleevec can affect the CML protein, Sutent does not. Sutent can affect vessel formation and these other proteins, Gleevec does not. And so what overlaps really is KIT. So we think that the major reason that Sutent and Gleevec work is because they inhibit KIT or PDGFRA. So this is the original trial that compared Sutent. So people who progressed on Gleevec, or 5% of them were intolerant or allergic to Gleevec, either took Sutent or took placebo. This is the progression-free survival curve, so obviously it was much better to take Sutent than placebo because half the people progressed within 6 weeks. But as you note, that Sutent is not nearly as effective as Gleevec. So in terms of talking about months or years of disease control with Gleevec, now we're talking about weeks or half a year. So better than nothing, not nearly as effective as we would like. Now, why is that? Well, if you go back to the things that make the tumor Gleevec resistant, what we figured out later, and not while Sutent was being developed because we didn't know any of this, what we figured out is Sutent is super great for inhibiting these mutations and not at all effective for inhibiting these mutations. And so in any given patient with multiple tumors, there's sort of a mixture of what mutations you have. If you have mostly these mutations, you'll do great on Sutent. If you have mostly these mutations, then Sutent is not likely to work. But it's more complicated than that. So once upon a time in this patient with 4 spread tumors, there was a primary tumor that had a KIT exon 11 mutation. So every time the tumor spreads, it still has this KIT exon 11 because these are sort of the children or the grandchildren of the original tumor. So they're still genetically related. If you look in there, you can say, okay, why are these tumors Gleevec resistant? And you can find these different secondary mutations. Now, the one in yellow is sensitive to Sutent. The ones in blue are resistant to Sutent. So what you can imagine when you treat this person is that this tumor might get better, and these 3 tumors will not. And so when your oncologist looks at the scan, a lot of times we see something's getting better, something's getting worse, something's getting the same. It becomes a lot more tricky because you can't just say success or failure. You have to say, what's the relative benefit? Are more things getting better or more things getting worse? The way I often look at it is if you have very large tumors that are getting better and very small tumors that are getting worse, I'm okay with that because I don't know that the next drug's going to work any better, and it's more important for you that I control the big tumors that cause problems than control small tumors. Ideally, of course, we want to control all of them. But even in this picture, it's more complicated because what we know if we do more sequencing is that even in this lesion that we think is sensitive to Sutent, there are other clones that are resistant to Sutent. And so and these also have other mutations as well. So there's a lot of heterogeneity. So when we treat this hypothetical person based on real molecular data, we would expect this tumor to get better, these to get worse. But over time, as we get rid of these cells, then these resistant cells will grow out, and that sort of limits how effective our therapy can be. So the impact, clinically is that you can see all kinds of responses. And as you switch from drug to drug to drug, you could sort of pick a tumor, and this tumor might get worse, and then you switch to another drug, it might get better, but then you have this tumor over here that was better and then got worse. And so unfortunately, with our current chemistry or our current therapies, oftentimes we reach the point where no single drug is going to control everything. And so then we still have to embrace the idea that failing slowly is better than failing rapidly. And switching to a new drug with unknown side effects might not necessarily be in your best interest until the time where we decide that your tumor control is not really justifiable on the current drug. It also makes it more complicated as we try to get to a third or a fourth or a fifth line therapy. If we think that everything is mixed and no drug is going to control everything, how will we recognize success? Because in your fifth line therapy, there's probably in any given patient at least one tumor that will grow, and using our conventional criteria, one tumor growing doesn't matter if 40 tumors are responding. We call that failure. And we need to kind of change response to understand that. So concluding on what's next, so some of you know sorafenib, which is a drug that's been developed for liver cancer and kidney cancer, has been tried in GIST, but its close cousin, regorafenib, which differs only by this one fluorine, has now advanced to more testing in GIST. Now, what do all these things have in common? Mostly KIT and PDGFRA. Sunitinib and regorafenib share the ability to inhibit the VEGFR receptors, which might potentially be a good thing. But on the other hand, hand, foot, mucositis, and hypertension all come from inhibiting these. And because Gleevec works without inhibiting these, we're not sure that we actually need those or not. This is just the trial. So this is patients after Gleevec, after Sutent, again, placebo-controlled. Again, we see the same picture, which has led to the controversy about how we do these trials, is that the average person could not even go 1 month on placebo without disease progression. And so can we really do placebo trials? Should we have this have been a placebo-controlled trial is, controversial depending on who you're talking to. And this drug works. Again, we're talking about a half a year improvement compared to placebo, which is not nearly long enough. But sort of the good news was that's the same as Sutent. So if we could keep finding things that work, maybe we could move regorafenib up higher, or if we find a new drug, maybe we can move that up higher. Maybe we could even move it up to frontline, depending. So what to do after regorafenib? Well, you really should see a GIST expert. There's other things that your oncologist could try, which are approved for other diseases, although your insurance company may not go for it. Sometimes the drug company will help you, sometimes not. Obviously, there's lots of clinical trials. Again, we spend a lot of time thinking about could we add surgery into the mix, and it's very complicated, and that's why you should be talking to an expert medical oncologist and also an expert GIST surgeon. There's lots of things in trial. Most of them are trying to target KIT in different ways. There's other things like Brian was talking about, PI3K inhibitors or mTOR inhibitors, which are trying to target downstream. So to summarize, and stay on time even, GIST is a molecularly heterogeneous disease. So it's not really one disease, it's sort of one syndrome. We think that tumor genotyping is useful. And for example, we can't decide even what your correct dose of Gleevec is without doing mutation testing. We need to change that. The fact that 6% is unacceptable. We know that we can do better after surgery. By giving Gleevec for some duration after surgery improves progression-free survival. We're still not sure, who needs to take it after surgery. If you have a 2% risk of recurrence, is it really worth it to take it for 3 years? We don't know how long you should take it. Now we're doing trials of 5 years. Some people have proposed that people should take it, continuously if they have a high-risk GIST, which theoretically sounds attractive. But on the other hand, if you're 32 years old and your life expectancy is 85, do you really want to take a medicine for 53 years? How much risk do you have to have before you would think that that was worthwhile, let alone economically feasible? But we do believe that the best way to cure is to cure people after surgery, and so we need to do more studies around that. And in advanced disease, getting drug resistance is still the limiting factor. We can control the disease for long periods of time, more than a decade in some patients, and others not that long. But ultimately, when the drugs stop working, that's when we start running into limitations. This is usually due to secondary kinase mutations. We need to pay, or your radiologist and your oncologist need to pay attention to imaging. I would read your report if I were you, and if you see funky little nodules being described, I'd ask your oncologist, show me the nodules and explain to me what's going on. Conventional management of resistance includes dose escalation, using different drugs, possibly surgery, and we definitely, need the ongoing research. We appreciate your support. We are trying to find a way to prevent this. First, we're trying to find a way to overcome it, but the long-term strategy is to prevent it and ultimately to get to a cure, so the day that we can come to Life Fest and celebrate life and not talk about what we still need to do to cure this disease.